All right, thank you to those who have joined. We are expecting a few more people, so I'm assuming that they will be joining us momentarily. My name is Olivia Henze from the New England QIN-QIO, and I will be moderating today's webinar. Thank you for joining us for today's webinar, Strategies for Rapid Cycle Improvement of Million Hearts ABCS Measures. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We'll take questions at the end, and I'll provide you instructions on how to unmute your line. At this time, I'd like to introduce today's hosts from the New England QIN-QIO, Kathy Roby and Michelle Calvi-Albert. Kathy will introduce our speakers today. Kathy?
Good afternoon, everyone. Well, I hope you're all a lot warmer than we are. It's actually snowing here. I'm very pleased today to introduce our presenter. Our first presenter is Hilary Wall. Hilary is a senior health scientist in the Division for Heart Disease and Stroke Prevention at the Center for Disease Control and Prevention. Hilary serves as the science lead for Million Hearts, an initiative from the Department of Health and Human Services, co-led by the CDC and the Centers for Medicare and Medicaid Services, with the goal of preventing 1 million heart attacks and strokes by 2017, which is just a few 8 weeks away. In this role, she leads a portfolio of scientific activities and lends expertise on strategies for cardiovascular disease prevention, including health systems change, clinical quality measurement, and health information technology. Hilary has 14 years experience in cardiovascular disease prevention in both research and state and federal government. She holds a Master's of Public Health degree in chronic disease epidemiology from the Yale School of Public Health. Our second presenter is Cindy Sun. Cindy is the lead cardiovascular project coordinator for West Virginia Medical Institute's Quality Insights. She has worked the Centers for Medicare and Medicaid Services Home Health Quality Improvement national campaign since 2009.
I'm just going to interrupt everyone for a minute. This is Olivia Henze from the New England QIN-QIO. I'm going to go ahead and mute all participants again. Hilary and Cindy, if you're on the call, after you hear the mute button, if you could go ahead and press pound 6 to unmute yourself, I'm just going to go ahead and mute all participants again.
The leader has muted your line. To unmute your line, press pound 6.
Press pound 6 to unmute yourself, Kat.
Sorry, everyone. We had a bit of background conversation. Cindy's primary responsibilities at VMI and HHQI include organizing our 100-plus network coordinators, assisting the home health agencies with integrating their data-driven quality improvement into their QI plans, and assisting with the integration of preventive cardiovascular care into the home health setting through the development of educational resources and the Home Health Cardiovascular Data Registry. Hilary, the floor is yours.
Great. Thanks so much, Kathy. And I'm really thrilled to be here to have this opportunity today to talk to you all about some rapid cycle improvement strategies for the ABCs of Million Hearts. So just a quick overview of today's presentation. I will provide a summary of Million Hearts and talk about the role clinical quality measures have played. Then we'll explore continuous quality improvement as a way to improve hypertension control and beyond, and examine the Million Hearts Hypertension Control Change Package. And then I'll finish up with a few additional resources that I think will be of interest to you all. So while we've seen a gradual decline in mortality from cardiovascular disease over the last 40 or so years, it still remains the nation's leading cause of death for men and women of all races and ethnicities. And every year, more than 1.5 million people will have a heart attack or stroke, and 800,000 people will die from these conditions. It's the leading cause of preventable death in people under the age of 65, which to me is huge. And the annual cost to the U.S. economy is estimated to be over $312 billion in healthcare costs, and lost productivity. So we all know cardiovascular disease is a problem for us. So to address this really large burden, back in 2012, the U.S. Department of Health and Human Services launched Million Hearts, which is a national initiative co-led by my agency, CDC, and the Centers for Medicare and Medicaid Services, with that ultimate goal of preventing 1 million heart attacks and strokes by 2017. Just in case you're not familiar with it, Million Hearts aims to keep healthy people healthy by reducing sodium and eliminating artificial trans fats in our food supply and reducing the prevalence of smoking through tactics like smoke-free laws. But we're also trying to improve the quality of cardiovascular disease-related care for those who need it by supporting clinical innovations, harnessing the power of health information technology, and focusing clinicians and the health systems in which they work on what we think are the most effective levers for cardiovascular disease prevention, what we call the ABCs. That's aspirin when appropriate, blood pressure control, cholesterol management, and smoking cessation. One integral strategy we used for focusing clinicians on the ABCs was supporting a small set, and the operative word there is small, but we supported a small set of evidence-based clinical quality measures. By doing so, our intention was to reduce the reporting burden on clinicians and help the country drive performance on the most effective cardiovascular disease-related outcomes. So we worked diligently with many public and private partners to encourage the alignment of a small set of clinical quality measures for the ABCs. And, this slide is very hard for you to read. You don't really need to know all the details, but it's one of my favorite slides. Across the top are the Million Hearts clinical quality measures, and down the left are a dozen or so public and private quality reporting programs. The yeses on this slide are where our measures existed when we selected them at the beginning of Million Hearts, and the pluses indicate all of the measure adoption and alignment progress that has been completed to date. And as we move forward with Million Hearts, we will be very well positioned with the CMS Merit-Based Incentive Program, which is part of the quality payment program that I'm sure most of you are very familiar with at this point. And you can see from this slide that our blood pressure control measure and our smoking assessment and treatment measure have near universal adoption, which to me is just tremendous. But having clinical quality measures present in reporting programs isn't really enough, right? We need to actually have data available so that we can understand where we're at as a nation on indicators of interest. So to enable that, our team developed what we call the Clinical Quality Measures Dashboard. And on the dashboard, and you're looking at some screenshots right now, we showcase data from NCQA's HEDIS measures, HRSA's Uniform Data System, through which all of the federally qualified health centers report, and the CMS Physician Quality Reporting System. And you can look at those data by year, state, and HHS region and do all sorts of different comparisons. We've got demographic information there so you can understand the generalizability of the data. Lots of really good stuff, and so I encourage you to explore that. But, improving on the ABCs is definitely not easy. We all at Million Hearts recognize that. However, there are studies that are in the published literature that show it's possible. And this particular run chart is from Kaiser Permanente, Northern California. It highlights how continuous quality improvement activities help them improve on blood pressure control from 44% to 87%, and frankly, they're beyond that at this point. These data are a little bit old. So it definitely is possible, and I know Kaiser is a huge closed system, but we've seen the same sort of improvement in much smaller systems as well, and much smaller practices as well. So it is doable. Sorry. Having trouble changing my slide. There we go. So the real question, though, is how was Kaiser able to make such incredible progress in hypertension control? the short answer is they made changes to their care systems and care practices. And I really appreciate the quote that's on this slide. It's not necessary to change. Survival is not mandatory. And if you're not familiar with W. Edwards Deming, he was actually a management consultant whose ideas became the cornerstones for what we now know as clinical quality improvement. And I think that this quote is particularly apropos in today's ever-changing healthcare environment that, as we all know, is rapidly shifting away from fee-for-service towards innovative pay-for-quality models like accountable care organizations. So we don't have to change, but if you want to survive, you basically have to. So, and I think you guys probably could give me a master class in this, but just in case you're not familiar, Plan, Do, Study, Act cycles, or PDSA cycles, are a way to conduct rapid tests of change. This was made popular, this particular model was made popular by the Institute for Healthcare Improvement. It's known as their Model for Improvement. And they have a great PDSA worksheet. The URL is on the slide. It's a really useful tool for documenting a test of change. And this method is just a way to test a change idea on a small scale. And then you learn from that small test, and then you quickly scale up and spread as progress is made. But how can we know what changes should be implemented in a clinical setting? There are so many places in the continuum of care within a patient visit and beyond where one could change. How will you know what will be successful? Well, I personally recommend begging, borrowing, or stealing from others who have successfully improved. And you can do this from the scientific literature if you're so inclined to look for articles like the Kaiser one I shared the run chart from. If you're really lucky, someone may have put together a change package for you. And a change package is an evidence-based set of strategies that are critical to the improvement of an identified care process. And spoiler alert, Million Hearts has done exactly that for you for hypertension control. You can access our Million Hearts Hypertension Control Change Package at the URL on this slide, but I'm going to review some of its components for you, and I really hope you find it useful. We've gotten a lot of great feedback from clinicians in the field who have used it, so I think it's going to be a good tool for you. The Hypertension Control Change Package is comprised of a few different components. We have change concepts, which are really just broad notions that can be used to develop more specific change ideas. And change ideas are, I just refer to them as the specific interventions for changing a care process. We've then taken our change package one step further and reached out to clinicians in the field who have shown great improvement in hypertension control for the tools that help them get there. And these tools can be adopted as is or adapted by your healthcare setting. The change package is then organized into 3 buckets. We have key foundations, population health management, and individual patient support. There's also a series of 7 case studies from organizations around the country to illustrate how practices have used systematic approaches to enhance information flow and optimize the workflow, and ultimately achieve significant improvements in hypertension control. So let's go through each of those buckets. Key Foundations offers ways to establish practice fundamentals for effective hypertension control efforts, and it's largely the best place on which to focus initial quality improvement. This includes making hypertension control a priority for your practice and training staff on accurate blood pressure measurement and recording. Let's see how the change package drills down from a specific change concept. So your practice decides that before broad quality improvement activities are done for hypertension control, you've got to focus on accurate blood pressure measurement and recording among staff so that physicians can have confidence in blood pressure readings taken by medical assistants and others. There are 2 major change ideas on which you can focus, providing guidance on accurate blood pressure readings or evaluating that proper technique is followed. And based on feedback from the clinical team, you decide training isn't an issue, but you need to evaluate that staff continue to use proper techniques systematically after training is received. And so the change package then provides you with several different checklists and documentation templates that you can use or adapt to meet this need. Population health management change concepts are focused on using data and standardized approaches to drive improvement among a panel of patients by proactively monitoring and managing hypertension practice-wide. And so for population health management, maybe your practice decides it wants to use data to drive improvement. So, it turns out your clinical staff don't think blood pressure control is a problem for the practice. You decide to use quantitative data from your electronic health record to highlight gaps in care. And there are two aspects on which you can focus: determining which metrics you should use to measure the quality of care delivered, or regularly providing clinicians with dashboards or report cards. Your practice decides it has a need for a clinician-specific dashboard for care related to hypertension control. And then the change package provides you with several examples of dashboards that have been implemented by healthcare settings who have achieved a high level of hypertension control. They include a wide array of graphs, charts, tables, and spark lines from which you can choose and adapt for your own needs, a smorgasbord of data visualizations, if you will. And the next slide lists change concepts for our third bucket, which is individual patient supports. These include ways that practices can leverage all care steps to better manage hypertension for individual patients. And these supports span the patient care spectrum, including pre-visit patient outreach, check-in opportunities, interactions during the visit, check-out, and after-visit reinforcement. So let's look at options for practice that decides to optimize patient intake processes. There are many points during intake where you could intervene, including changes to patient education materials, patient goal setting, documenting blood pressure and flagging abnormal readings, or medication reconciliation. And your team decides changes are needed on the latter. The change package then provides you examples of medication reconciliation templates and electronic health record reports. And so, again, I encourage you to look at the full change package. I've just highlighted a few aspects of it, but this tool, what's great about it is it's customizable to meet the needs for your practice. So please do explore it with your quality improvement team, and feel free to send me feedback on anything you like or don't like about it. Now I want to take just a minute to explore a few specific resources developed by Million Hearts within the change package that can help with hypertension control. And so if the change package is looked at as your full toolbox, these are just a few of the tools that are in it. One of the strategies from the change package is the use of self-measured blood pressure monitoring, also known as home blood pressure monitoring, but with additional clinical support. And the crux of SMBP, or self-measured blood pressure monitoring, with clinical support is this patient-clinician feedback loop concept, where the patient has a way to transmit their self-measured readings, medication side effects, or information about lifestyle habits to their clinician, and then the clinician has a way to interpret that information and transmit back titration or lifestyle modification advice. So a few years ago, we released a guide called Self-Measured Blood Pressure Monitoring Action Steps for Clinicians. And this was really our attempt at aiming clinicians how to really implement widespread SMBP with their patient population. So this is a comprehensive guide really containing everything a clinician needs to know to implement one of these programs with her patients. This includes checking a patient's home blood pressure cuff for accuracy, training patients to use their cuff, and the frequency with which patients should check their blood pressure. Another strategy highlighted in the change package is using standardized hypertension treatment protocols for blood pressure control. And these go by many names. They're also known as care pathways, healthcare algorithms. It doesn't matter what you call them, but they're a standardized approach to treatment. And protocols send a strong signal to clinical staff that hypertension control is a priority. They also help to reduce clinical variability when the science is strong, and they better enable all members of the healthcare team to do things like titrate meds. So they really can be a great support to the concept of team-based care. And on our Million Hearts website, you'll find a customizable protocol template, which is highlighted on this slide, as well as examples from 4 health systems that have effectively implemented a hypertension treatment protocol and implementation guidance from experts in the field. So basically everything you need to implement standardized hypertension treatment protocols in your setting. But anybody who is actually in practice knows having a treatment protocol really isn't enough. You need to be able to successfully embed it into your electronic health record workflow. And this is not easy. I will be the first person to admit that. So to help figure that out, CDC partnered with the Office of the National Coordinator for Health Information Technology, or ONC, to host what I like to refer to as the Protocols Challenge. It has this long title, EHR Innovations for Improving Hypertension Challenge. And through this effort, we named 2 practices from across the country as winners for sharing useful tools for standardizing blood pressure control within their practices. And if you go to the URL on this slide, you can find the actual electronic tools or snapshots of those tools that they use from their electronic health records. So hopefully that will be of use to you. And standardized treatment protocols are not only useful for blood pressure control. We've actually expanded our suite of materials on this topic to include tools for tobacco cessation and cholesterol management as well. Again, you'll find customizable templates, example protocols from the field, from practices who have done well in these areas, as well as some implementation guidance. And then to provide extra support to the implementation of tobacco protocols, we've worked with our CDC colleagues in the Office of Smoking and Health to create a tobacco action guide, which is what we call it for short. But this guide really pulls together the best evidence-based strategies and tools to help clinicians with their cessation efforts. And we'll be putting out similar guidance on cholesterol management next year. So as we've worked with health systems to gather best practices in hypertension control, some of them realized that they have a non-trivial number of patients with multiple abnormal blood pressure readings who have not been officially diagnosed with hypertension. And when we look at national surveillance data, they actually confirm this issue. So we've dubbed this phenomenon, quote-unquote, hiding in plain sight. And a few years ago, we wrote a viewpoint in JAMA that highlights how some large health systems have addressed this issue. As we did the research for the JAMA viewpoint, we tried to look for some common themes, and we used those themes to develop a 4-step process that others could emulate. These included using data to determine if a practice might have undiagnosed hypertensive, setting definitions for a patient with potentially undiagnosed hypertension, exploring electronic health record data to find patients who meet those definitions, and lastly, implementing a plan to confirm whether or not those patients actually have hypertension. And for practices interested in this kind of data exploration, which frankly is also very applicable to other conditions like finding people with undiagnosed cholesterol or finding tobacco users you didn't know were in your practice or finding undiagnosed diabetics, we've developed a landing page on the Million Hearts website that showcases a variety of tools, including a great, I call it a mini change package because it's relatively short, that was developed on this topic by the National Association of Community Health Centers, who worked with, I believe it was 11 federally qualified health centers across the country to do exactly this kind of data exploration. And so they pulled all their tools together for other practices to use. We also have a hypertension prevalence estimator tool that we showcase that can help you figure out whether or not your practice might have this problem. And we have tools like a catchy whiteboard video that can really lay out all of the challenges related to finding undiagnosed hypertensive, and there are some other tools as well. So, after that complete information overload, I would be happy to take any questions that you have.
Thanks, Hilary. So in order to ask this question, you can press #6 on your phone to unmute your line, or you can post a question in the chat box. Please just make sure to send to all participants when you ask a question in the chat box. Again, #6 to unmute your line, or you can pose a question in the chat box. I think actually Michelle Kelby-Albert, while we're waiting, does have a question for Hilary.
Hi, Hilary. This is Michelle. Thank you for your presentation. It was a lot of great information. And so I'm in the physician office practices every day, and I'm just trying to figure out if you could come up with maybe one suggestion, kind of soundbite of how a physician practice who is interested in trying to work on this. So the change packet is, as you know, I mean, it's great information, but a lot of information. What would be your first thought of where they might meet? Do you have any advice on that? Just a simple start place?
Yeah, well, I really do think that the key foundations group, I think some of those things are almost like must-haves before you really do any successful quality improvement in a practice. So if hypertension is something that your QI team wants to focus on, we have found universally you've got to have a physician champion who's helping to spearhead that and helping to spread it throughout the practice, get buy-in from all the clinicians. And it generally needs to be a physician who acts as that champion, though I have seen some other types of clinicians step into that role. So I think that that's really key. I think that, laying out any of those foundational pieces that your practice might be missing right now is a great place to start. And then once you've got that strong foundation in place, if you can do some sort of gap assessment, where are the challenges? And you can ask all of your staff, not just your physicians, not even just your clinicians. Ask your front-end staff, where do they think some of the gaps are with patients? A lot of times we find patients aren't coming back for follow-up visits. So that may be a really smart place for you to start. And they may have some great suggestions as to how you can do that. So I think it's about laying the foundations and then doing a gap assessment or an environmental scan of your practice to figure out where are the biggest challenges and, frankly, then the biggest opportunities for improvement.
Hi, Hilary. This is Kathy Roby from the Home Health side, and I have a question for you. I'm currently working on a program on reportable parameters for the home health. One of the pieces that we are focusing on is trying to engage physicians so that we can get a partnership established between the physician, the home care provider, and family unit so that everyone agrees upon a reportable parameter for the self-monitoring and some type of a response plan in the home setting so that there's less unnecessary phone calls back and forth to the physician practice. Do you have any suggestions or recommendations for us on how we can better engage and to actively participate in this?
You cut out right as you said after engage. Who are you looking to engage?
We're trying to get an open flow of communication going between the physician practice and the home health provider and the patient family unit so that a set of guidelines can be agreed upon between all three, that the patient family unit is doing the blood pressure self-monitoring, the home health provider may be participating in using your materials as well as the physician practice for education, but we're having some difficulty in engaging the physician community, and I'm wondering if you have any suggestions or recommendations.
Gotcha. Okay. So I think, in the atmosphere in which we're living right now when it comes to healthcare, team-based care gets thrown around a lot. Sort of, a term that's catchy and people like to use it. But truthfully, there's a ton of evidence that shows physicians don't have time to do everything. And so we have to figure out, how do we get home health professionals promoted as part of that care team for the patient? And I think that physicians understand the value that home health professionals can bring to the table, but if they don't, then that, to me, is something that needs to be conveyed as soon as possible. So really just selling the home health professionals as an integral part of the care team, and frankly, we already talk about patients and their families being part of that care team. So to me, this is just an extension of that, and we just have to figure out how to make the case if it hasn't already been made.
Thanks, Hilary. Looks like we have a question in the chat as well from Diane. How do we register with CMS to start reporting measures for the billion hearts measures?
So there is no sort of formal registration. That is a great question, though, one I've been asked before. If you look in, let's talk about, we have present day and then we have future, right? So currently there are, as you've seen on that sort of crazy slide that I showed, within CMS, the Physician Quality Reporting System, the EHR Incentive Program, Medicare EHR Incentive Program, and a whole host of other CMS-related quality reporting programs incorporate the Million Hearts measures. And so for many of those programs, you have, as a clinician, the opportunity to pick and choose which measures you report on. So that's sort of the informal way to start reporting on the Million Hearts measures of interest. And again, you'll notice when we look at blood pressure control across those various reporting programs, NQF-18 is the common measure that one can use to report on blood pressure control. Moving forward, in the merit-based incentive program, incentive payment system, so many acronyms that it's hard to remember them all, in MIPS, we have worked closely with CMS and through the comment period on the proposed rule, we have worked to include those Million Hearts ABCs measures in MIPS moving forward. So if you are participating in MIPS and you are, there are various, I'm going to use the wrong terminology right now, but there are various measures groups for different professionals. So there's like a cardiology measure group. The ABCs are in that group. There's one for internal medicine, family practice. The measures are in both of those groups. So you can use a specialty measure set, report on those, and you're going to hit all of the ABCs measures for Million Hearts. Alternatively, you can pick and choose your own measures through MIPS, and again, you could go ahead and pick the measures of interest here. For the alternative payment model side, that I know a little bit less about. I think we're all still learning this area, but many of those programs that qualify as APMs, again, already have the Million Hearts ABCs measures embedded in their quality reporting structure. So it's sort of a win-win on either side, but there is no formal registering to report on the ABCs.
Thanks, Hilary. If there's not any more questions, we can pass it over to Cindy. Again, if you have any questions for Hilary that you think of, you can always put them in the chat box and we can get to them after Cindy's presentation.
Or feel free to email me. I'm very amenable to that as well.
Thanks so much, Hilary. So, Cindy, the floor is at yours.
Well, thank you very much, and I just want to reiterate that was a really great presentation, and I hope I'm glad it's recorded. I would like to watch those slides again. Hilary, you did a great job. I want to thank everybody for the opportunity to be here. I'm from the HHQI, and before I say home health and everybody from physician practices hangs up, the home health quality improvement campaign, even though everything is focused on home health, the tools and resources I wanted to discuss today are applicable to all healthcare settings. So it doesn't matter what your healthcare setting is, whether you're physician's offices, nursing homes, rehab, hospitals, everything is available, all but one, and I'll tell you about that when we get to it. So out of time restraints today, I'm just going to focus on the blood pressure control resources that support the Million Hearts Initiative, everything that Hilary was just talking about. But there are equal amounts of resources for not only smoking, but also for aspirin and cholesterol management. So we'll go ahead and go through blood pressure control, and we'll talk about staff education first. Just as Hilary was saying, there are many different evidence-based resources, and what we've done at HHQI is we've collected them for the Home Health Agency and put them in the best practice intervention packages. And this cardiovascular health part 1, which is aspirin and blood pressure, and then there's part 2, cholesterol and smoking, ABCS. These are chock full of not only the evidence that supports the changes, but also different tools, resources, success stories of agencies and providers who are before you that have been working on this. We also have the different webinars, for instance, the one that's listed here, the role of the therapist in the cardiovascular care. The physical therapist, especially in our therapy-only cases, is just integral to our cardiovascular care. But in many home health agencies, the therapists, what they bring to the table, they're not really utilized other than mobility issues. So this was a wonderful webinar presented by Cornetti and Kraft, Cornetti and Cindy Kraft. It was available. It's still recorded. It's part of the university. And it offers free CEs not only for nurses, but also for therapists. And it's valuable not only for the therapists, but for the nurses to realize how to utilize the skill set of the therapist beyond just mobility issues. And finally, for the clinicians who really just want kind of that down and dirty turnkey information, we have the fundamental focus, blood pressure and smoking cessation VTIP, that really breaks through everything and just gives it to you straight, exactly what you need to know when going into the patient's home. Now, for additional staff education, as I mentioned before, we have the HHQI University. Do remember, this is for all clinicians across the board, not just home health. Now, there are multiple courses, but these were just a few that I pulled out. Master the Maze of Blood Pressure Medications, and then Blood Pressure Smoking Cessation. Those are they are available for free CEs for the nurses, but everyone who attends the course receives a certificate of completion. I'm only mentioning that because if you're initiating your quality or you want to bulk up your quality program focusing on blood pressure control in the home health setting, you can integrate this as part of your annual competencies. Everyone who attends will receive the certificate. Now, the blood pressure information for patient education, these are professional videos that we had made, and you can see they also support the Million Hearts Initiative that Hilary was just talking about, how to check my own blood pressure. If you have a patient who responds better to visual media than audio, more of a visual learner, these are very short little video clips, can either be streamed live if you have great internet in your patient's home, or if you're like me, I have no internet in most of my homes. So download to your tablets, your laptops, whatever you have. And it can be playing in the home while you're doing something else. You can see there's multiple titles here. The blood pressure medication management, that's another good one. And there are fantastic ones on smoking as well. So these are available for everyone. If you are in an office setting or if you have a large group of people accumulating, you can play this on the television and just have it run through a couple of minutes. That's all it is. Workbooks adding the structure to the visit. My Heart Healthy Workbook is one that we created. You can see the different languages that it's available so that we do treat our undisclosed population to make sure that they are getting the languages which they wish to read this in. And it focuses on multiple different areas, and it gives structure, more of a skeleton to the visit so that it can be accomplished in between visits as well as when the clinician is in the home. All of this is on the HHQI website. If you don't have an account, you just create one. It takes about 30 seconds. Again, it's all free. We only have that so that we can show traffic to CMS. All of this is funded by CMS. And if you hover under the Education tab, it will pull up the tips and you can see where to click on the best practice packages. I know it's difficult to read, but it's under the Education tab, as well as the university is there. Now, additional resources that we have to support the Million Hearts Initiative or the cardiovascular improvement is something called the Cardio LAN. This is a group that meets quarterly. In fact, our next meeting is in December. It's on the third Thursday, and it focuses on everyone, just a general group of providers who are interested in improving cardiovascular. We have clinicians, we have home health aides, we have physicians, physicians' offices, nursing homes, really all settings across the board. And you have national speakers that come in and present information. It's a time for networking, asking questions, and really getting down and dirty as to what can we do to make this work, getting it down to the application phase. We really wanted to have it a place where people could come together, speak freely, ask questions, and then try to make a difference at a national level. To join this, you would just go to on the blue toolbar on the website, under Cardiovascular, you'll see Cardio LAN. And I'm only pointing out the map on this page because this is open to the public, and it will show you the agencies in your area who are currently enrolled in the Cardio LAN. So as soon as you join, your agency will show there as well. And I know coffee is a bad word, so forgive me for saying it, but whether we like it or not, that COP is going to drop. We don't know if it's going to drop today or if it's going to drop 2 years from today, but we do know that it's going to drop for those of you in home health. And we also know, we can assume, coffee is going to be a very strong point. And just as the National Association of Home Health and Hospice, NAHC, has been saying for 2 years now, get your coffee in place and get them to the sustainable level prior to the dropping of that COP. Once the conditions of participation drop, there's going to be so many other pulls on your resources that this being off of your plate will really give you a head start. So focusing on that, what we've done at HHQI is create different courses. Now, whether you are new to home health or you're new to quality improvement, or maybe the word coffee hasn't even entered your vocabulary yet, we have Coffee 101, which gives an overview of the whole process. And then each of these topics, you can see hospitalization, medication management, cardiovascular, are available for the performance improvement plan. And the reason that I particularly like this, even though you can't read this screen, on the left-hand side of this, this is cardiovascular, but on the left-hand side of each of these PIPs, the performance improvement plan development packages, you'll find potential problems. What was the problem? Is the fact that you have blood pressures that are too high, you have dietary issues with your patients, or maybe there is a reporting issue. And then on the right-hand side, when you open this electronically, you just click the links. This is a list of links for each of those problems. So you don't have to dig through everything. You can just click it and go right to it. Now, this is something that I really am so glad that Hilary mentioned. She mentioned Pave Your Path, which is the IHI's Model for Improvement of Rapid Cycle Improvement, PDSA. IHI just approached us about 4 years ago and wanted to do this just for home health. And so this is available to everybody, but it focuses on implementing PDSA Rapid Cycle Improvement in the home health setting. We've created it into a 4-part series. You can watch it all, you can watch part of it, but each one is accredited for CE. And it helps understand that we're no longer looking at 2-year improvement packages. We're looking at improvement with one patient, 1 week. Quick turnaround, fix it, tweak it, move on. Get this going and get it spread throughout the agency. Now, one last thing I wanted to touch on was data. In home health, the Oasis is a very good tool. Yeah, I'm glad I'm doing this remotely so you can't throw anything at me, but I really, the Oasis collects a lot of good information. It does its job, but it collects very little information on any of the ABCSs. For that reason, we created the Home Health Cardiovascular Data Registry. focusing on very simple measures, the exact same measures that Hilary was talking about that physicians' offices are reporting. This is a way to integrate and show alignment between the physicians' offices and home health agencies. So in aspirin, was the patient on aspirin? Yes or no? Real simple question. Blood pressure. What was the patient's final BP? Cholesterol? Have they had a lipid screening in the past year? And if so, do you happen to know the LDL-C? And smoking? Was the patient screened for tobacco use? And if they were a user, did they receive any type of tobacco cessation counseling or pharmacotherapy? Very basic question. I don't even like the word registry for this thing because when I think of registries, I think of multi-5-hour process per patient. This is very simple. And the beauty is that as an agency, you select which of those ABCS topics you wish to focus on each month. So if you only want to focus on blood pressure, that's all you do. Basically, I'm just going to summarize it quickly. 12 or fewer patients for each topic area that you select will appear in the registry. It's populated with all of the demographic information from the Oasis. You just answer those questions that I mentioned. So if you chose blood pressure, you'd open 12 different patients. They're already pre-populated. They're randomly selected, so you don't have to go through who qualifies and who doesn't. And this is all available through the HHCDR, through the data access portal, which is on the HHQI site. Anyone that's in home health that isn't familiar with this, just contact either Kathy Roby or myself, and we'll be glad to help you access it. Just a quick glance at the report that you would receive. You can see it does give you what are your agency, your compliance measure, compared to all of those who are entering data for the registry across the nation. So it gives you a little bit of comparison and also lets you know how you're doing. I went through all that rather quickly because I wanted to take a moment and pause for questions because I'm sure by now some of you probably have more questions for Hilary, but I'll just pause for a second and see what questions you have.
Thanks, Cindy. That was a fantastic presentation. Again, if you'd like to ask a question for Hilary or Cindy, you can press on to unmute your line, or you can pose a question in the chat box. Please just make sure you're sending it to all participants. Thank you.
Olivia, if you don't mind, while we're waiting, I'll just go ahead and mention one more thing.
Of course.
Because of the fact of where you all are located, this is New England, I just want to mention that HHQI is actually going to be in your area. We only get to do this twice a year, and we're going to be in Saratoga Springs with a data-driven quality improvement workshop on, let's see, it's going to be November 17th in Saratoga Springs, New York, which is just up from Albany. It is free to everyone. It is part of a post-conference of the New York Home Health Association conference, but it is available to everyone in any healthcare setting and any state. But registration is required, so if you're interested in that, let me know and I'll get you the information because space will be limited. But I thought while we were on your registration just opened up last week, and it would give your agencies an opportunity to get in on it quickly if they were wanting to come over there.
Cindy, this is Kathy, if I may. If you could forward that information to Olivia and I, we would like to share that with some of the home health providers that may not have made this wonderful call today, because I think that would be an excellent program to try and get representatives from each state. If we sent a core group even, then they could bring it back and share it.
Absolutely. And Kathy, as a matter of fact, it'll be coming to you tomorrow. But it's on the website right now, but I'll be glad to send it to both of you and Olivia.
Thank you.
Kathy's eyes lit up. This is Olivia. Cindy, Kathy's eyes lit up when you mentioned the training that you were having.
Well, I mean, we're here to talk about Million Hearts, but when we're talking about quality improvement in general and how to take this cardiovascular data that they're going to be collecting and focusing on and how to put that into a coffee and make it sustainable so that it does meet those COPs, it's kind of killing a lot of birds with one stone, and that's what I wanted to make sure that everybody was aware. Yeah, absolutely. We'll get you the info.
Thank you. And again, we're going to open it up for some questions. You can press pound 6 on your phone to ask a question to Cindy or Hilary, or you can pose a question in the chat box. So we'll give it a couple moments right here for people to do that.
Cindy, while we're waiting to see if anyone does have a question from the group, I'd like to circle back to the question I posed to Hilary. I was doing some research over the last couple of days, and I happened to be walking through one of the best practice intervention packages from the test, and in it you had a section on obtaining and promoting physician engagement, and that is, as you of all people would know, that is one of our biggest projects, is to try to make this a true partnership between the home health provider and the physician to get a response plan established for the patient-family unit, to get parameters we can agree on, medication response we can agree on. And I was really excited by the terminology that you had in there on some examples. Do you have any additional examples or suggestions that we can share with the providers to help them to increase the physician engagement and participation in working with us?
Well, I think it goes back to the basic relationship. Many physicians, and I don't want to speak for your area, I'm only going to speak for mine, but after doing this job as long as I have, I've heard that this is a national issue. Many physicians are simply not aware of what home health can do, period. Not just focusing on cardiovascular, focusing on what the acuity of the patient, and helping the physician understand, first of all, prioritizing and making it as limited effort on the physician's part as possible is all but mandatory. Physicians, I mean, if you think about it from their point of view, what they're hearing from us from home health, I need you to sign this form. I need you to sign it now. No, that's not the right way. I want you to sign it. You're going to have to sign it this way. Because of the fact our payment is relying on their completing the documentation correctly. And I think if I was a provider in a physician's office, I would feel, one more thing. And so I think as home health, we have to break down that barrier and not only explain what we are able to do and where our value is, but then also simplifying it. And for that reason, another favorite thing, I didn't put in this presentation, but there was a fax tool. And it's just very simply, when you're completing the 485 and getting ready to send it in with everything else, the fax tool it's just a one-page sheet, and you can use it as a fax sheet or embed it in something else. But it just explains to the physician that you're focusing on the ABCS. And as an example, you're wondering if this patient should be on aspirin or not. It's just like if you receive a patient who's diabetic and they're not taking any anti-glycemic medication. So the question to the physician is, just wondering, should they be on any medications for the diabetes? Yes or no? No? Okay, no problem. Same thing here. Should they be on aspirin? Or this patient, what blood pressure would you like us to control? When would you like us to talk to? I know every agency has their own parameters, but working with the physicians, like you were talking about, and developing a protocol will make it easier for everyone. So I think reestablishing those relationships and understanding that the physicians are just so bogged down, just like home health is, all healthcare settings are, just seeing what we as agencies, what can we do to make the physician's life a little easier? One thing that I've heard over and over from successful relationships in communities, and this is very simple, and New England is very intelligent, so you guys probably already have this in place, but have one person at the agency be the communicator with this one physician. Instead of having 10 clinicians calling the physician at different times throughout the day, have it set up, and then there's one call at a certain time, maybe even once a week. And then that's when all the patients are covered. And that includes all of the blood pressures, all of anything else that needs to be. of course, there's going to be times that you need to contact outside of that once a week. But if setting that time aside, the physicians I've spoken with, they've really enjoyed having that, everything is concise into one conversation instead of having to stop in between their patients to take a call from multiple different home health providers. So things of that nature. And I'm sorry, Kathy, I went off onto a different tangent there, but I really think it's all about reestablishing the relationship and demonstrating what we in home health can do and how we can help with this patient get their blood pressure under control. We do more than just helping a patient reestablish mobility, and we help more than just dressing wounds. We can do more in home health, especially focusing on these measures.
Thank you, Cindy, very much. Do you, Hilary, have any final notes that you wanted to talk about before we end today's webinar?
No, I'll just say thank you. This was a great opportunity, and I loved hearing Cindy's presentation as well. I think there's lots of synergies between physician practices and home health that we all need to work together to explore.
And thank you very much for the opportunity. It's always great kind of chance to hear what else is going on and how we can collaborate. So thank you for that.
So thank you both for such a fantastic presentation. I just have a few last-minute announcements before we end the call today. When you close out of this webinar, an evaluation is automatically, if you could please fill it out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing the computer with someone else, you'll receive an email tomorrow with the link. Our presentations and Hilary are posted on our website. And please be on the website. Thank you again to Cindy and Hilary, and I hope everyone has a wonderful day. Thank you.